Coronavirus SARS-CoV-2 is a new type of coronavirus that was first detected on December of 2019 in the city of Wuhan, China. It began as a local epidemic outbreak that turned out to be a global pandemic. The virus is known as coronavirus SARS-CoV-2, and the disease it causes is called COVID-19. The term coronavirus is due to the crown shape surrounding the virus. The COVID-19 clinical profile is mainly respiratory, but many cases also present neurological symptoms like headaches, anosmia, or muscle aches. There are also discovered multiple clinical profiles where the central and peripheral nervous system are affected as well. The purpose of this video is to review and inform the society about the disease caused by the virus from the neurological view, explaining its complications, clinical manifestations, diagnosis, treatment, and neurological assistance.
COVID-19 can cause encephalopathy, but the level of neurological involvement can be variable. The patients with COVID-19 suffer from severe hypoxia, and as a consequence of alveolar disorder from gas exchange from the infection, it can produce a neurological damage, decreasing the level of consciousness or a coma. Since the brain doesn't receive enough oxygen, it produces an hypoxia in the central nervous system, making the brain cells, mitochondria, increase their anaerobic metabolism and accumulate more lactic acid. This produces a vasodilatation, cellular edema, blood flow obstruction, ischemia, tissue congestion, causing an increase on intracranial pressure. Coronavirus can make its way into the central nervous system through two different ways, hematogenous and transneuronal. Although the SARS-CoV-2 invasive neurocapacity is unknown, the hematogenous way could be easier because of the hematoencephalic barrier disruption associated to a storm of cytokines, which can alter vascular permeability, produce coagulopathy, and pro-inflammatory effect. The cytokine storm produces a rupture in the hematoencephalic barrier, causing homeostasis inflammation and the alteration. On the other hand, the virus can infect the peripheral neurons and travel all the way to the central nervous system. It is believed that the transneuronal way through the olfactory way can relate with earlier damage of many patients that present anosmia, a symptom that is well known as an earlier clinic sign of COVID-19 infection.
Review of all the literature on PubMed pertaining to the neurological manifestation of SARS-CoV-2 using key terms such as COVID and neurology, COVID and nervous system, we found the following information. The average incubation period is 5 days, median range around 3 and 7 days with a maximum of 14 days. During the viral replication phase, which lasts for several days, subjects may present with mild symptoms as a result of the effect of the virus and the innate immune response. Lower respiratory tract involvement occurs when the immune system fails to stop the spread and replication of the virus, and respiratory symptoms arise as a result of the cytopathic effect on lung cells. The main clinical manifestations of COVID-19 are fever, dry cough, diapnea, and acute respiratory stress. However, many infected subjects may be asymptomatic or present with mild symptoms such as headache, non-productive cough, fatigue, myalgia, and anosmia. The incidence of neurological complications from SARS-CoV-2 is unknown. Patients with severe COVID-19 are more likely to have neurological symptoms than those with mild forms. So we have that headache, myalgia, dizziness, and fatigue are the most frequently described non-specific symptoms.
Patients with high suspicion or confirmation of COVID-19 presenting neurological clinic, a complete neurological examination should be performed in addition to that complementary test, indicate depending on the patient's clinic. Where it's considered necessary to rule out neuroinfection, an SF analysis shall be performed, including a study of serum immunoglobulin producing and SF inflammation markers and eyeball microbiological tests. The diagnosis process before a respiratory clinical picture is well defined with RT-PCR in nasopharyngeal or lower respiratory tract sample. It's not the same when there are neurological conditions that I wanted to rule out neuroinvasion, such an encephalopathy. In that case, the microbiological study that demonstrate or discard infection by SARS-CoV-2, not forgetting the most common virus like Helix. It's mandatory knows others coronavirus. Both humans and animals can directly affect central nervous system, having affected virus. The central nervous system having detected the virus in CSF. Biopsies and intrathecal production of antibodies can be demonstrated similar. There is currently no antiviral treatment that has been shown to be effective in curing COVID-19. The World Health Organization has initiated the Solidarity clinical trial to assess the efficacy to various medicine in treating COVID-19.
A lot of patients with COVID-19 require urgent care, hospitalization, or intensive care units to ensure an adequate care. As a result, it is unpredictable to preserve as much as possible a health activity that allows a patient evaluation, but however, foresight and training are clearly two of the most effective measures to maintain an adequate neurological care during an emergency situation.